Hi, my name is Greg Kashkarian, and I'm a cardiologist at Pima Heart and Vascular here in Tucson, Arizona. And I'm very happy to be participating in this educational session on women and heart disease. I'll specifically be talking about women and coronary artery disease, or coronary heart disease, as I'll be referring to it in the lecture. So what should women be considering when they think about coronary artery disease? Well, you should be thinking about yourselves, first of all. Are you at risk? How does coronary artery disease develop? And what causes a heart attack? What are the symptoms of a heart attack? And what should you do if you've experienced those symptoms? So you might be familiar with this kind of an image. We have a mother here. She's got her baby in hand. She's talking to her husband, probably planning some travel that they're going to be doing and making airline reservations. And she's looking at the menu to prepare a meal for her family. And you women all know that you take care of a lot of people, your babies, your older children, your husbands, often your parents. But in the context of this talk, I want to stress to you that you need to pay attention to your health. You can't always put your family first. I like this image, kind of a super mom there. She's got her baby protected with headgear, and she's beating all the other fans out of a fly ball there. As you notice, she doesn't have any protective headgear herself. So again, pay attention to your health. So what are the leading causes of death in women after the age of 65? Well, first, I shouldn't say first, fifth on the list, first on this slide is Alzheimer's disease. 6% of women will succumb to that. Slightly more common is stroke at 7%, and a little bit more common are lung diseases at 9%. Then you jump up when you include all the cancers, 19% of women will die of cancers. But the largest number of women will die of heart disease. 25% beats out all the other cancers combined. And stereotypically, heart disease has been thought of as a man's illness. But I want to try to show you that that's not necessarily the case. So this slide demonstrates the prevalence of heart disease in men and women above the age of 20. And you can see that it increases decade by decade. Men do have it more commonly at any given age, but you can see that women's risk is substantial. And we usually think of a rule of thumb that women have heart disease about 10 years later than men do. Okay, so how do you decide if you're at risk? Well, there's certain risk factors that you can't do anything about. Getting older is a risk factor. Men at the age of 45 or women at the age of 55 start to develop a higher risk. Having a family history of heart disease, and family history means a first-degree male relative by the age of 55 or a first-degree female relative by the age of 65. First-degree means siblings or parents. Then there are the modifiable risk factors, elevated cholesterol, high blood pressure, diabetes, which may not be considered modifiable in the sense that you can make yourself not have diabetes, but it is treatable. And in fact, diabetes is such an important risk factor that we often call it a heart disease risk equivalent, meaning the risk of a heart attack in a person with diabetes is just about as high as a person who has already had a heart attack. And then smoking is a huge risk factor. So what are the goals? Cholesterol is an important one, and the goals have changed over the years. We used to have discrete number goals depending on your risk factors, but we now know that all of us have too high of a cholesterol. So we mostly focus on people who are at high risk to try to lower their cholesterol. So very high risk people are people who have known heart disease, symptomatic vascular disease, a history of stroke, symptomatic peripheral vascular disease, people who have a high risk by their Framingham risk score. There are websites that you can plug in your demographic information and can tell you what your 10-year risk is. Over 20% is considered to be high risk. If your LDL cholesterol starts off at 190 or above, that's high risk. And all of these groups of people should be on a high intensity statin. That's a statin that provides about a 50% reduction in cholesterol. The The two statins that are in that category are atorvastatin and rosuvastatin, used to be called Lipitor and Crestor. Now, patients with diabetes should be at least on a moderate intensity statin with a goal to lower the LDL cholesterol 30 to 50%. But some diabetics have an even higher risk based on their Framingham risk score, or are very difficult to control diabetics, or have other factors that we can talk about a little bit. Intermediate risk patients, a risk between 5% and 20%, should consider to be on a statin. And the things that would lead them to consider that are so-called risk enhancers. And that also plays into the diabetics in determining moderate versus high intensity. So risk enhancers include a family history, having chronic kidney disease, having metabolic syndrome, having chronic inflammatory diseases like rheumatoid arthritis. Ethnicity can play a role. For instance, South Asians have a higher intrinsic risk, probably partly genetically, partly due to diet. Biomarkers or lipids, particularly high triglycerides, or elevation of inflammatory markers like C-reactive protein. Having an abnormal ankle brachial index. Also conditions specific to women like early menopause or a history of preeclampsia. These are all risk enhancers that should increase the likelihood that you're put on a statin medication. In patients who continue to be on borderline for making a decision, often we get a calcium score, and that's a CAT scan that measures the calcium content of the coronary arteries. Blood pressure goals have changed over the years. Currently, we consider high blood pressure to be a systolic over 130 or a diastolic over 80, and we consider prehypertension to be a systolic between 120 and 130, and a diastolic between 70 and 80. Diabetic goals should be to keep the hemoglobin A1C below 7, generally in the 6 to 7 range. Fasting glucose in the 70 to 130 range, or an after meal glucose below 180. Also in diabetes, it's important for having an ideal body weight and exercising regularly. And really, those are important modifiers for virtually everybody. Finally, the goals for smoking is none. That isn't to say that cutting down on smoking isn't good for you, but there isn't any safe level of smoking. All right, so what causes atherosclerosis? Atherosclerosis being the development of plaque in arteries. Well, it starts with altered endothelial function. I don't want to go into this slide in too great a detail, but I want to say that the endothelium, which is the inner lining of the artery, acts as a barrier to accumulation of lipids or inflammatory cells that can migrate underneath the endothelium into the subendothelial space. And when the endothelium is damaged by diabetes, high cholesterol, high blood pressure, it alters that barrier and allows white blood cells to attach to it. It allows lipids to accumulate, so that what we see is the development of plaque, which starts as what's called a fatty streak. Lipids accumulate, they get engulfed by these inflammatory cells called macrophages that become foam cells, something called smooth muscle cells, and T cells, which are a type of white blood cell, also migrate into the growing plaque. Finally, this plaque enlarges, the endothelium thickens and becomes what is called a fibrous cap to try to protect the bloodstream from this growing collection of cholesterol and inflammatory cells. These foam cells break open and release the cholesterol into the plaque, so that you have this sort of acellular, amorphous conglomeration of cells and debris. Now, what actually precipitates a heart attack is a break in this fibrous cap that allows the bloodstream to now be in continuity with the subendothelial space. You can hemorrhage into this plaque, and the debris of the plaque extrudes into the bloodstream, which activates the clotting system. And you can see that in the bottom slide there, where the plaque has extruded into the bloodstream, and now you have platelets that get activated and the vessel clots off. So vessel occlusion is what causes a heart attack and is generally precipitated by plaque rupture. So what are the symptoms you might experience if you are having a heart attack? Well, the most common symptoms are chest pressure or tightness or squeezing. It's usually substernal, meaning directly behind the sternum, or it can be on the left side of the chest. Patients often describe that it feels like an elephant is sitting on their chest. Sometimes the discomfort is just discomfort and not overt pressure. Sometimes the symptoms can just be shortness of breath, or shortness of breath can be a common component of the chest discomfort. People often have left arm heaviness or discomfort. The pain can radiate to the jaw. People can feel dizzy or faint and often will break into a sweat. Now, it is said that women have atypical symptoms. Interestingly, this is not as true as what you hear on the street. If you look at this poll of what women and men experience when they're having a heart attack, you can see that women have chest pain just as much as men do. Interestingly, though, they have more other symptoms than men do, and that's part of the reason why they're sort of have the reputation of having atypical symptoms. The other reason that is that elderly people are much more likely to have atypical symptoms, and women are more likely to get this disease at an elderly age compared to being a younger age. All right, so what should you do if you have these symptoms? Get medical attention immediately. Call your doctor, call 911, and don't wait for your doctor to call back before calling 911 if you're feeling extreme symptoms. Do not delay. It takes 15 to 20 minutes for heart muscle to start to be irreversibly damaged. So that's kind of your grace period. We call the golden hour. The first hour of a heart attack, you can have damage to the heart that you can measure in the bloodstream, but generally there will be no measurable decrease in heart function if an artery is open within that hour. So don't hesitate in getting medical attention. So what do we do to treat a heart attack? The most important thing is to get the vessel open, and that usually means mechanically. We use balloons, angioplasty, and stents, which are on balloons. We use medications. Many years ago, when we didn't use balloons and stents, thrombolytics or clot busters were our main way of treating heart attacks. Nowadays, most people do get angioplasty, but there are other medications that act as adjuncts to mechanical therapy, antithrombotic medications, which we call blood thinners, antiplatelets like aspirin, Plavix, Effient, Prasugrel. And so we combine these together to open the vessel and keep it open. And I thought I would show you all what stents look like. On the left, you see an expanded stent on a balloon and an expanded stent off the balloon. And on the right, you see an expanded and an unexpanded stent against somebody's finger. So you get an idea of how big these are. Most arteries are about 3 millimeters wide. So that's how big an expanded stent is. So in summary, it's important to know that heart disease affects you, women. Risk factors can be identified, and if you have symptoms, it should prompt immediate medical attention. Heart attacks can be treated, and remember, women, pay attention to your health. Listen to your heart.